Good evening and welcome everyone to the online shoulder and elbow school. I am Juan Aguilar. I'm part of the junior committee and I would like to thank you all for joining us tonight. The topic for today's session will be terrible triad of the elbow, and we are extremely honored to have with us two renowned experts in elbow surgery, Professor Samuel Antuña from Spain and Dr. Joideep Phadnis from UK, who will share and discuss their cases. I would also like to introduce the junior panel selected for today, with Simone Cassin from Italy, Apetrei Catalin from Switzerland, María Delgado from Mexico, Kunal Mohan from Ireland, and Louis Thielman from Belgium. Without further delay, let's get started. Professor Antuña, please, may you start with your first case?
Hello, everybody. Hello, Juan and Valentina. Thanks for organizing this. I think this is a great idea from CESEC to teach young surgeons. So I will be using the first half of this session with a few cases. There is no tricky questions. There is no tricky answers. These are cases that each of them try to show something that I have learned throughout the years. Perfect. So, Luis, let's get started with this. This is an X-ray, lateral X-ray of a patient that came to our institution in 2006. Obviously, pain, the elbow, etc. What could you tell from this X-ray?
We see an elbow which is a little bit dislocated. The ulna is dislocated posteriorly. We also see a coronoid fracture. I think it's more than 10 millimeters, and I think there's also a radial head fracture. So it's probably a posterolateral elbow luxation.
Okay, so this is the elbow is not congruent, that's for sure. How many bones do you think are broken there?
I would say 2.
Okay, so and which part of those bones?
It's hard to tell on the lateral view, but I think
Okay.
we have the maybe a basal fracture of the coronoid, and then the antero-superior part of the radial head. But
Perfect. So what would you need, Luis, to be sure that what's going on in the elbow? What would you ask for this? This is the only image that I'm showing you. What would you ask if this is your patient? What would you? Sorry, I keep showing you the result, but doesn't matter really. What would you ask if this is a patient coming to your emergency room?
Well, if it's possible, I would like a coronal view, and then also a CT scan.
Okay, good. So sorry, I'm just changing because I have lost you guys in my screen. That's why. Are you still able to see the X-ray?
Yes.
Perfect. So this is 2006. Those days, I was not usually asking for a CT scan in every single patient with a terrible triad. Simone, do you think this is right today? Do you think it is okay to treat a patient with a suspicion of a terrible triad without asking for a CT scan?
No. I think it's mandatory.
It's mandatory. Would you agree, all of you? Sorry, I'm just playing with the names, but Jose Maria, would you agree?
Yes, I think every patient should need a CT scan of the elbow for deciding the treatment.
Okay, so let's say, and we don't have the CT scan because, as I said, this is the only image that I have here. If you don't have the CT scan, your diagnosis, right? What would be your treatment option, Kunai?
I suppose on the assumption that it's a typical kind of PLRI mechanism, you would want to, I would approach it from a lateral EDC split approach. I want to first assess the radial head to see how many fragments it was fractured in, see whether it is either fixable primarily or would require replacement. I would then try and visualize the tip of the coronoid to again see how much of it is fractured, whether this would require a bony fixation or a capsular repair would be sufficient. Based on that, then I would then address the anterior capsule, usually with a transosseous suture through the ulna. And then based on this X-ray, it seems that the coronoid fracture is quite large, as mentioned earlier. So I'd anticipate that this would require, in my hands, a retrograde screw fixation through the ulna to try and fix this fragment. And the radial head looks to be in more than 3 parts, I would guess. And again, having seen your post-operative X-ray, I would likely proceed to a radial head replacement, and then address the lateral ligaments.
Okay, so this is the X-ray. Who can tell me which type of radial head implant is this? Any of you?
It's a monopolar.
Okay. Is it meant to be loose, or is it not meant to be loose?
Do you mean inside the radius?
Yes. Is this a fixed stem?
No, it's a fixed.
Okay. Is it anatomical, or it is a spacer?
No, it seems to be an anatomical one.
Okay. Do you think the fit of the stem is right within the canal?
Yeah, I think maybe there is a little bit of overfitting. It's a little bit too long. The cut. I will cut a little bit more in a case like that, because it's beyond the coronoid. So in a lateral view. Okay,
so probably you would all agree that the stem is quite thick. It is anatomical because it's not symmetrical, it's asymmetrical. But the fit seems to be, and the cut seems to be just fine. And then the coronoid was fixed with 2 screws. Jose Maria, do you prefer screws from the back, or you prefer screws from the front?
From the back.
Why?
I think it's a much safer approach, and you can get some good results within the approach.
Okay, do you rather use from the back cannulated screws or non-cannulated screws?
Cannulated screws.
Do you think these in the image are cannulated?
Sorry, pardon?
Do you think the ones we are showing in the X-ray are cannulated?
I don't think so.
Yeah, no. So in the past, we didn't use cannulated screws. Now I use cannulated screws all the time. But these were screws that were not cannulated many years ago. Probably some of you were still in the school, in the kinder school. Okay. So this is the X-ray 5 years later. So Catalin, again, what do you see in this X-ray? 2 questions. Do you think the coronoid is healed? That's the first question. The second one, do you see anything strange in the radial head?
I see some ball resorption around the radial prosthesis, which I think is normal. It's something that we anticipate. But on the AP view, I see some sclerosis on the medial facet of the coronoid, so that's a bit uncertain for me. Perhaps it's some sort of instability or non-union.
Okay, I'm not giving you clinical information. This patient is perfect. It's almost full range of motion, no problems with rotation, no pain. She just came because we were doing a study those days, and we called her. You said that bone resorption after radial head arthroplasty is normal?
It to some degree, yes.
Why do you think that is happening?
Because of the mechanical load. I think the stem is
perfect. So the stem is very well fixed. So there is what is called stress shielding because the proximal part of the bone is not loading.
And this is very common in implants that are fixed into the stem. It's not common, in fact, it doesn't happen in stems that are loose fit. So would you be worried because of the stress shielding or not?
I think I would at some point, if it gets exaggerated, I would get worried. But I think for the moment the stem looks well fixed. So
okay, this is 10 years later. What do you think now?
yeah, so I see some progression of the
Big
bone.
change?
So
There is a little bit of progression. Look at the AP view.
Yeah.
AP view a little bit. Are you worried now? Patient is perfect.
I mean, if the patient doesn't accuse anything, I would just follow it up. I think more often than every 5 years.
Okay.
To check
good.
on the progression.
And the coronoid is healed or not?
I think the coronoid is healed. I think the radio ulnar joint looks congruent. So
yeah, and then on the lateral view now you see that the coronoid it's healed. Because sometimes when you read papers about healing of the coronoid, you can never tell that this coronoid is healed. So you know, be skeptical about when somebody tells that the coronoid is healed, because you with the radial head it's very difficult to know. You need a special X-ray like this one that is a kind of oblique. Okay, stress shielding is very common. It's usually asymptomatic. You don't need to do anything to this patient apart from telling the patient that there is some bone loss, but usually that does not lead into problems. And this is our experience in the long-term follow-up, and we have published on this. And this is also others' experience. So stress shielding is not normal. That's not the right word. It is common. It's most of the times asymptomatic, but you need to follow these patients because maybe in 25 years they become loose. Okay, Jose Maria, what do you see here?
We have an anterior and anteposterior view and a lateral X-ray from the right elbow. You can see a posterior dislocation with a fracture of the radial head.
Okay.
With more than 2 fragments. And I'm looking. And it looks you have you also have a coronoid process fracture.
Is it a big coronoid fracture or a small from this X-ray?
I would say it's a small one.
It's a small one. Okay. So this was again 2007. It was my patient. It was La Paz University Hospital. No CT scan. So the elbow was reduced. The patient was taken to the OR. Coronoid was not. The surgery was not done for the coronoid. And this is the X-ray. Actually, the patient was 9 months later. Very painful. Rotation was just fantastic, but she was stiff. Jose Maria, what do you see?
Well, what was the clinic? The pain rotation. It looks
yes, what you're thinking. Exactly what you're thinking.
It looks stiff in the sigmoid process, and I don't know.
Yeah. Can you, if you see this joint, do you see it symmetrical?
No, it looks a little bit asymmetrical in a little bit.
Why would this be larger than this one here?
Right, a ligament damage or?
Well, it could be that it's unstable but the ligament was just fine.
Okay.
Why would the lateral part of the joint be distracted? Do you see that? Is this a normal radial head arthroplasty?
No, it's not a normal one.
It has a kind of a supplement here, doesn't it?
Yes.
Why do you think the surgeon did this? I was not probably the surgeon because I've never used this, but it was in my institution. So
From the extension of the fracture?
Yeah, I don't know, but it's strange. And it seems that this part of the joint is lengthened, doesn't it?
Yes.
So if you lengthen the lateral part of the joint, then you distract the lateral part of the ulnohumeral joint, and there is contact in the medial side. This is a typical case of overstuffing.
Okay.
And the main reason overstuffing happens is because the surgeon believes that the radial head is a primary stabilizer of the elbow. And when they implant the trial, they want the elbow to be very stable. And the only way you can get a stable elbow without a lateral collateral ligament repaired is by lengthening the lateral column through the radial head. So beware of this, because overstuffing happens usually because the surgeon tries to stabilize the joint with the radial head, and the radial head is not a stabilizer, it's a secondary stabilizer. It helps healing the ligament because of the Cames effect, but it needs to be really where it should be, and it's in line with lesser tuberosity. But here you could tell that it's in line, but it's not really in line. It's much more proximal. And when you have overstuffing, the patients complain of limited motion in flexion extension, no in rotation. These patients usually have full rotation. So, Kunal, what would you do for this patient?
So I suppose if their symptoms are severe, and on the assumption there's nothing else such as infection that may be causing their symptoms, you would discuss them potentially revising the radial component to something more appropriately sized to minimize the effect of the overstuffing.
Okay, so you would replace the radial head, is that right? For a properly measured one and with the right length.
I think so, given the timeline since the index instability event. I know in theory one could consider an excision in an isolated radial head situation, but given the instability, I would revise it to another replacement.
The patient, do you think the patient is unstable? She's stiff.
No, but that's what I would consider potentially revising, I think, in this scenario.
Yeah. So this is La Paz.
Mm.
So the radial head was removed. Obviously, the stiffness was corrected. And this is her, like, I don't know, maybe 15 years after the excision of the radial head. She's weak, obviously, with the arm. She has some valgus, as you can see. She has mild arthritic changes, but she's asymptomatic in terms of pain. Do you think we are crazy?
No, not at all. She's very happy.
So we have very recently published our experience with this procedure, and it seems that it's not that crazy, you know. I think revising with another radial head might be a good option, but I'm not sure it's better than just removing the radial head in the long term. We need time for this, and obviously time will tell. But if you don't have experience with elbow arthroplasty, or you don't have the facility or the resources to do another replacement, or if you are in trouble, probably it's okay just to remove the radial head, provided that the elbow is stable. Okay, Simone, what's this?
So, Samuel, can I comment? Just to totally agree that when I started out with these cases, which are quite common, like Samuel showed with a painful radial head, whether it's loose or overstuffed, I always used to plan to put another prosthesis in, but I almost never have needed to do that because once you take the prosthesis out and you spend a lot of time doing all this stuff and you screen the elbow, it tends to be stable. And you can always even reef the ligaments a little bit to make it a little more stable. The only situation where you probably, I think, need to put something in is if you have a longitudinal instability. So you just check for that at the time. But I'd agree with Samuel. And don't be in a rush to do a total elbow. Like, think about doing one thing at a time, seeing the outcome, and many times you won't need to go and do something further.
Yeah, great, Joideep. I think because I was not mentioning that, obviously, that is only an option if you don't have longitudinal instability. If you have longitudinal instability, that would be a big mistake. That would be a negligence because you have to check that the elbow is stable. Thank you. So Simone, what do you see here?
It's an elbow dislocation with a very, very big coronoid fracture. I think it's a basal one, and so type 3. And I would say also a quite big radial head fracture. I see at least 2 pieces, but I'm not sure there are just 2 pieces.
What would you need to know more?
I would do for sure a CT scan here too.
Okay, what do you think we did in La Paz?
I think accordingly to the previous cases, you went to the DOR and checked the situation of the bone and maybe replaced the radial head and try to fix the coronoid. I'm not sure that the kind of fixation. I think that in this case,
no, I'm not really talking about the fixation. I was talking about another imaging, and
okay.
It was a kind of joke, you know, because at the very beginning of our career and experience, we jumped into the cases without proper imaging many times, and that's the message that today that is not something that you should do. I mean, you should go to every single case today with a CT scan. I don't think unless you are in a third world country in which you have to, you know, deal with the patient with whatever is needed. But in our countries, complex head that seems to be complex as well. What would be? Do you like the right-hand tone classification? Are you aware of that classification?
Yeah,
by Adam Watts and his team.
Yeah.
You said it was a basal coronoid, and I agree with that. And in Adam's classification, this is what he calls a B plus. I must confess at the very beginning when he described this, I said, this is worthless. But now it's completely the opposite. I think he was clear enough to pick it up, and I think and you will see why. This is a case that it's B plus because the radial head is injured and the coronoid is comminuted, but it's basal, as you perfectly said. So would you treat both or just the radial head or the coronoid?
Yeah, I would do both.
Okay, so that's what we did. Again, screws from the back. These are cannulated. This is a more recent case. And the radial head, is this a loose fit or a press fit, Simone?
I think it's a loose fit.
Loose fit. So this is not usually an implant that needs to be filling the canal, okay? So this is him. 8 years later, he's perfect clinically, no problems. I am showing only good cases today. What do you see different, and this is for the radial head only, in this image and in that image? Look at the AP and lateral. Is this patient losing bone or is this patient creating bone?
I think creating bone.
This is something that we also found in the paper that I mentioned before. Some of these loose fit implants develop what we have called the pedestal. I don't know if that name exists in English, but we call it pedestal, which means that some of these really develop bone underneath the radial head, and we believe it's bone that is created by the motion of the stem inside. We are not sure. Some of these pedestals are really big and lead to stiffness in pronosupination. So if you find this and even as anossification around the radial head when you use loose fit implants, that is something that can happen. Patient was just fine. And that was the message I wanted to show. Okay, so let's see here. Luis, this is no x-ray, but we have 2 CT scans. What can you see here?
So here you have a basal fracture of the coronoid without the radial fracture. So this makes it Wrightington B without the plus.
Okay. Is this posterolateral, posteromedial? What do you think?
It's hard to say because if it's just a posteromedial facet, it's more an PMRI, but this can just be an axial load as well.
And how can you actually load the coronoid and fracture it like that way without fracturing the radial head?
if you fall in supination, I guess, I don't know.
So the patient, I believe, and I know because this is one of our patients, and this patient had the lateral collateral ligament torn, so the elbow was dislocated. If you dislocate your elbow, as you said, with a basal fracture of the coronoid, it can be that the radial head, when the impact goes, the radial head falls down and really gets a space to dislocate without contacting the capital. Okay, so how would you treat this, Luis?
I would go for a buttress plate with a Hotchkiss approach, I guess.
Okay, and you would fix the ligament as well?
I would check if there's any residual instability.
Yeah.
Would you
expect this to be stable or unstable?
I think these are really hard to predict. I would just see after fixing the coronoid.
Okay. So usually these patients have the lateral collateral ligament detached. So it's worth just having a look laterally, a small incision, and just reattach the ligament because it's 5 minutes. And okay, but buttress plate is exactly what you said. Okay, this is the X-ray 9 years later. What do you think?
It looks fine to me. Maybe it's open on the lateral side, but it's
this is a very simple plate, not specifically designed for the coronoid. I personally don't like the coronoid plates from any company. I try to use the small compact hand plates and bend them, or plates that the guys for the foot and ankle team they use. I use any plate that can buttress. And the thing that I wanted to mention is that when you do this medial approach, you have to be very careful with the nerve, because we also showed a couple of years ago in our series of coronoids that when you go medially and you do this surgery, the rate of ulnar nerve symptoms is pretty high. It's probably worth reading this paper because it's not in a top journal, but it sends some messages on medial approaches. Okay, that's my part. Joideep, all yours. Thank you, guys. Good job.
So this is two of my cases that are treated recently, or not recently, a little while in the last 4 or 5 years. So this one is a 43-year-old actor, right and dominant, playing football, fell over, no history of dislocation, so he didn't feel the elbow dislocated, isolated injury and neurologically intact. So let's move to the X-rays. So Simone, what do you see here? Talk me through the imaging.
I will say there is medial facet coronoid fracture. For me, the radial head seems fine, and I don't see nothing more special.
Okay, so what are your thoughts on managing this person? He's in your clinic 1 week afterwards.
I would say I will test the valgus stress, sorry, and if it opens, I will, and it will open for sure because it's a medial facet coronary fracture. I will say that I would suggest surgery. Maybe I will study before a little bit with a CT scan.
So let's just track back one second. So let me ask you, what pattern of elbow instability is this? So all of Samuel's patterns, he showed one, but the majority were posterolateral rotatory mechanism. So what's this one?
It's a posteromedial one.
Okay, so I'll ask one of the other guys, Jose Maria. So with a posteromedial pan, I agree. This is like, so if you see an isolated coronoid fracture, no radial head fracture, your trigger in your brain should be thinking, is this a posteromedial instability? Okay, so what hidden injuries are there? So we can see the coronoid. What other injuries are there likely to be that you can't see on the X-ray?
Probably LUCL.
The radial.
Yeah. So the lateral collateral ligament, yeah. We and Samuel mentioned that in his last case. So that tears because of varus, yeah. So it's a varus injury. And what's the other thing you should be thinking about? Which other soft tissue might be injured and important. So, who was it at the beginning? Simone, you mentioned a valgus force would lead to gapping, right?
Yeah.
So it's actually the other way around. This is predominantly a varus injury. So the term is confusing, posterior medial rotatory instability, because it makes you think there's a medial soft tissue injury, but there's not classically the MCL anterior part is intact, and the other soft tissue injury is the posterior MCL is to think about, okay? So the classic injury is coronoid, posterior MCL, and lateral ligament, all right? Now you have to, I'll give you some more information. So here's the scans, CTs, because I'm sure you would have all asked for CT. So in my hospital, coronoid fracture equals CT. So before they, they get that, that's what happens. So have a look through here. And Kunal, why don't you tell me what you see and how you're going to decide on management?
Yeah, so based on these CT slices, there's a relatively large coronoid fragment extending kind of anteromedially. There appears to be no associated radial head fracture. So you would have to address the coronoid fragment through internal fixation, which I would do via a medial approach. I would also look to address the LUCL complex through a lateral EDC split approach with soft tissue anchor for the LUCL complex, and then also to address while medial to address the posterior band of the MCL.
In the CT scan, is the elbow congruent or incongruent on this view? Just have a look at it again.
Appears to be relatively congruent, but some evidence of a possible drop on one of the slices on the video there.
Pretty minimal. That's the shape of the way the olecranon changes shape as it goes lateral. That's not a drop. That's a normal. So that is actually pretty congruent joint. So remember with CT scans, they're taken with the arm generally flexed. So often you can get a congruent scan. And if you really want to check for stability with the imaging, you can ask them to do the CT in extension. Sometimes patients come with an MRI, and we'll discuss whether there's any value to MRI, and they're done in extension. So sometimes you'll suddenly see a much more unstable elbow on an MRI because it's done in extension. However, the elbow is congruent here. So how about the other guys? Any other thoughts? I'm going to show you another scan. So Kunal's for fixation, and I think that's pretty reasonable, but I'll show you some more scans. So that's a classic anteromedial facet fracture. So it doesn't, Simone, you were saying about having a valgus injury. So the sublime tubercle, which is where the MCL attaches, is usually intact in these cases. All right. So if you look carefully at the 3D, the sublime tubercle, the fracture exit just in front of the sublime tubercle. Okay. So have a look at the AP2D again. It's not grossly incongruent. And can you see there's a little fragment at the back where the posterior MCL might have been injured? Okay, so let's ask someone else. So Louis, what do you think about management? So Kunal's for surgery.
So I think the latest research shows you can conservatively, but only if there's a small fragment, and it's less than 2 millimeters, I think. If it's clinically stable, and then there's some room for, and then if there's no subluxation, so if the joint looks congruent on CT scans, I'm a little bit in doubt because of the fragment looks, I think it's 3-4 millimeter, but you have to, I'm doubting a little bit.
So this is a case where it does create doubt. Okay, so that's why I've put it up. So Jose Maria, what about you? So Louis is going to pick up the phone and call his friend and say, I'm in doubt about this case.
Clinically, how's the valgus and the varus?
Okay, so that's a good point. So the question is, how are you going to assess stability to make your decision? Because this is an equivocal case. No one can tell you 100% what to do in this situation. So
you could ask for some stress X-rays in valgus and varus and
yeah. So who's going to do those stress X-rays? I'm going to break down really what happens in real life. So who's going to do the stress X-rays?
Oh.
So have you ever asked for stress X-rays?
No, not personally, but I have.
Me neither. I wouldn't trust a radiologist or radiographer to stress this elbow, right? So stress X-rays are out. Any other ideas on how we're going to make the decision on what to do for this person? Because there has to be some logical way.
You can do an EUA in theatre, and then from there you could proceed.
So an EUA in theatre, and that's a very reasonable thing to do. So you take the patient to theatre, put them through a range of motion. Kunal, what tests would you do in theatre? Or would you just move?
So I suppose you're looking to assess your lateral complex, which I would do with the shoulder internally rotated and do a posterior lateral drawer. And then I would also look to assess the medial structures, assessing your force in a externally rotated shoulder position with some elbow flexion.
Yeah, so you would do a varus valgus test. You would do a posterolateral draw. That's very good. So the posterolateral draw is looking for the lateral ligament injury. Good. But EUA needs a general anesthetic, right? I don't know about your lists, but my lists are really, really busy. So it's hard to put a patient on the list just for an EUA. That means someone with a distal humerus fracture might get cancelled. So EUA, yes, I agree, it is a very good way, but it's not a practical way. And generally, when you take patients to theatre under EUA, we generally end up operating on them. So the EUA turns into surgery because you're there. Are there any other ways preoperatively? So some of those tests you mentioned, you can do pre-op as well to look. So you can test the lateral collateral ligament with a draw, even in a patient with an injury. Would anyone do an MRI? Does anyone use MRIs? Adam Watts, who you know, we've mentioned him already, he would get an MRI for this case. Would anyone else? No? Yes?
I will, if it will be possible in the hospital to have an MRI in such a short time.
Okay, let's say it's possible in your hospital.
If it's possible, yes, for sure.
Yeah, so unless the MRI shows it's dislocated in extension, that's not the reason you're going to get an MRI. An MRI is for the soft tissue injuries.
Yeah.
But we already know what the soft tissue injuries are. So it's almost certain that the ligaments we said earlier are injured. So an MRI for me doesn't add a huge amount of information unless it shows instability. And like you say, for most of us, it's hard to get. So it's all about stability. So I'll show you how we do it. So are you all aware of the posterolateral rotatory draw test described by Sean O'Driscoll? So I would get you to all examine. This is a paper we published on it. So this is a patient with a similar sort of injury just being examined in clinic. So if you wait a week or so, you can examine the patient, and that's showing a grade 3 test, which means the LCL is definitely torn, okay? There's also a test called the varus grind test, where you put the arm up like this and you move the arm. And if you feel grating and grinding with your hand, that tells you the trochlea is riding into the coronoid, okay? And that's what you want to avoid. You want to avoid that problem because that's the thing that leads to arthritis. So let's say this draw was positive. So are we going to theatre? How do we decide whether to fix the coronoid? So Louis, you mentioned 3 millimeters, 2 millimeters. Do you know any better way of quantifying the coronoid size? The leading questions.
How do you mean? I don't know. I always measure it on CT, but you have to calculate in the cartilage. There's a.
So that's difficult, isn't it? If you can't see the cartilage.
That's true.
And if you work in Japan and your average patient height is 5'2", or you work in Norway and your average patient height is 6'3", then 3 millimeters is very different, right?
That's true.
So metric measurements aren't very good. So don't be hung up on those measurements. Remember, in all the papers you read, people will generally say 2 or 5 millimeters because those are classic numbers we use in orthopedics. They're not actually based on very much evidence. So it's really the joint stability that's the most important. Okay, so looking for the draw, getting an MRI, getting an EUA, but you have to prove some way that the joint is stable or unstable when you're deciding. This is just the way I prove that or refute it. So read this paper. That would be a good one for you to read, and I'll share you, this. So this is another paper called the Coronoid Height Index. So it's a percent measurement. I won't go through it all, but it's a more logical way of measuring coronoid bone loss, all right? And this is what we use. I'm not going to go through it in detail, but it's a paper that's worth reading for you, okay? So, and what it shows is that consistently these measurements are quite common. Again, I'm not going to go through that too much. So this is what I did. So, sorry. So he had a lateral collateral ligament repair only, all right? We didn't repair the coronoid in his case because the joint overall was stable. He had a negative varus grind test, so there was no dropping in, but he had a strongly positive draw test. So if you think back to the principles, the lateral ligaments torn in varus, there is a chance you can protect the coronoid by fixing that, okay? Because the rest of the joint was congruent. And you can see on his post-op, this is a 2-year x-ray, there is a step in the coronoid, but the joint is nicely aligned and it hasn't developed arthritis. And I actually know he did well because I play football as well. And I was playing football and I fouled this guy. I went to pick him up by his arm and he said, you did my surgery. And I was picking him up by the arm I operated on, and thankfully he was doing well. It didn't dislocate. It's a true story. Okay, so this is a paper to read about. So again, from us on that logical way. So the principle of the case is not every single coronoid needs fixing. Many do, and you're right. You were all right to recognize that was a tricky case. But you have to have a logical approach. So don't reflexly fix everyone because Samuel showed you there's a high rate of ulnar nerve complications with that medial approach. You do it when it's necessary. And then this is that other paper. I can drop those for you. Okay, let's go to the next case. So who haven't I asked? Let's go with Simone. And I asked you last time, Jose Maria, you go first. So what do you see here? 72-year-old lady, fall, closed injury, neurovascular intact.
Well, you can see an olecranon fracture, a coronoid process fracture, and the radial head looks like it with 3 or more fragments. Yeah.
Good. So how do you classify this injury?
It's a Mason 4 or
okay, so that's the radial head.
The radial head.
What is this injury called?
I don't really know though.
Okay. So anyone else? Any of you other guys? Kunal, what do you think? What is this injury? How would you classify it in your mind?
So it's a Monteggia variant transolecranon fracture dislocation.
So you've said two different terms there because they're two different. So transolecranon fracture dislocation is one thing, and a Monteggia variant is a different thing. Which one is it? If at all, if at either of them.
I would say it's probably a Monteggia variant. Maybe wrong.
Okay, so what's the variant?
Actually, sorry, I correct that to a transolecranon fracture dislocation because it's not a clear anterior posterior dislocation of the radial head on the imaging that I can see.
Louis, Simone, do you have any other opinions on what to call it or name it?
I agree with the transolecranon fracture.
Okay. All right. So these are confusing. People get hung up on calling it something. So I was being a bit mean. I was trying to get you to name it, but I try and move away from naming the injury or over classifying things. What you want to know is what is broken and how badly it's broken and how do I fix it, and does it need fixing? Yeah. So I just call these type of injuries a proximal ulnar fracture dislocation. Okay, simple. So the proximal ulnar is fractured, and there may be an injury to the coronoid, there may be an injury to the radial head, there may be an injury to the what else? What's arguably more important than the bones? The soft tissues, yeah? So always think about the ligaments. So in all elbow instabilities, and in these, there's often a soft tissue injury as well. So I'll show you a CT. So this is the sort of case where he's going to need surgery, right? This isn't too much of a debate. Okay, so that's the CT scan. So what do you guys see there? So Louis, tell me what you see and how you're going to go about addressing this.
You see anteromedial coronoid fracture, transolecranon fracture, and then a radial head fracture. I don't know for sure, but I think you start with fixing the ulna so you can restore the length.
Yeah. What do you notice about the coronoid compared to all the other cases we've seen so far?
It's far more distally, the fracture, far more
it's bigger, isn't it?
Well, yeah, it's bigger.
Yeah. And look at it. So look where the sublime tubercle is. Remember on the other cases, the fracture was in front of the MCL. Here, the sublime tubercle is within the fracture. So this is a true basal coronoid fracture. So this proximal ulnar fracture dislocations, their coronoid fractures tend to be much bigger, much bigger. So very different to all the other ones we looked at. You recognize that, yeah?
Yes.
So it involves a sublime tubercle. So it's much more unstable. So treatment principles. You already started talking about it. So how are you going to approach it?
So
what position you're going to put the patient in first?
I don't know for sure, as I haven't had that much experience with these.
Yeah.
But I would think laterally. I don't know.
Yeah. So, anyone else? Anyone have a strong opinion about lateral or supine positioning? We can forget about prone. So if the way I decide, many times people will go lateral, but this is a case where there's a high chance you need a buttress plate for the coronoid. Okay, you can fix it with screws, but the coronoid is key in this fracture. So if I think it's going to need a buttress plate, I want to be able to bring the arm up into this position. So, and that's much easier done supine. You can still put the arm across the face to do the olecranon, but you can then bring the arm down to do a medial approach, you know, through your same window. So what about the radial head and the olecranon? How are you going to approach that, Simone?
I will approach the radial head through a Catalin approach.
So what's the skin incision going to be for this case?
I think I will do just one skin incision posteriorly to avoid to injury to match the skin.
Yeah.
And then go subcutaneously to the Catalin approach to assess the radial head and fix it. And the notch case approach for the coronal fracture.
Okay, so when you make a posterior skin, I agree. I would make a one incision for this because we have to do something to the ulna. The nicest way to get the radial head is to use a Boyd approach in this. Because imagine your skin incision. Can you see my marker moving on the screen? I'm not sure. But the skin incision is on the back here. And if you just sneak down the lateral side, and you can see how you can almost see the whole radial head by flexing through the fracture, you will see the whole radial head will just appear in front of you. The best view you can have. And then you can fix it, you can replace it, you can do what you want, and then do the other bits. All right. We've got 5 minutes, so I'll just move on. So there's a few other things I want to show you about this case. So that's that. So this is our framework for thinking. So again, this just describes all these different injuries in proximal ulnar fracture dislocation. So there's a couple of papers on that. So I would urge you to read that. And more importantly, there's just this month a review article on how to fix all these proximal ulnar fracture dislocations we wrote. So that's worth looking at. So here's that fracture. So you can see here, there's a simple ulnar fracture. The coronoid is, we call it simple because it's in one big piece, and then a complex radial head fracture. So this tells me I need to have a radial head replacement available. I need a coronoid plate potentially, and I need something to fix the ulna, okay? And the thing I wanted to show you, this is the intraoperative view of that case. Look at the soft tissue, just so you understand what I was saying about the medial collateral ligament. This is the medial collateral ligament on the coronoid. You can see it's perfectly intact. So on the sublime tubercle. And what happens is the rest of the elbow falls away from this fragment. So this is the only connection to the humerus. That's correct. And the rest of the elbow's fallen away. So that's why the coronoid is so important to fix back in that case. I'll show you what I did. So these are the images. So we did a radial head replacement and a plate and a separate plate for the coronoid. But you could have fixed the plate with the coronoid with screws, but you have to be sure it's reduced perfectly. So for me, a buttress plate was better in this situation. This is the article. If you want to read it, I think it will be really helpful for you. Okay. Any questions about those cases or comments? I think we have 2 minutes left.
Actually, from the chat, I have a question, Dr. Phadnis,
yes.
About this last case. What's your order of fixation? You start with the coronoid, you start with the olecranon or radial head. What about the ligaments?
Yeah, it's a great question. And it can be tricky to get right in your head. There's no perfect order, but you can see in this image, what I've done is I've actually placed sutures in the olecranon, and I've put some K wires in the olecranon to keep it stable. At this point, I've already done the radial head because the radial head, when you flex the elbow, you can see it, like I said to you guys. So I've already done the radial head. If I'm worried about the length of the radial head, because sometimes it's very comminuted in that area, the PRUJ, then I'll put a trial in, but in this case, I'll put the definitive implant. So radial head first, olecranon temporary, coronoid fix, olecranon plate, and then in this case, there was a lateral ligament tear. I just put a small anchor in there as well. But there's no correct, sometimes you'll find you can't fix the coronoid when the ulna's been fixed. So you might have to change your tactic, but I would highly recommend doing the radial head at the beginning when you can flex through the fracture.
Right. And what about Professor Antuña? Do you agree, or do you do something different about the order of fixation in these complex fractures?
It's interesting because I do it differently, but I think this is more clever. So what I do is I do lateral decubitus with the arm falling down, and I would just fix the coronoid through the fracture side of the olecranon. I would rather use screws instead of a plate if possible. If it's not possible, I would not hesitate to use a plate for the coronoid independently. And then I would fix the olecranon on the coronoid and the diaphysis. And the radial head, I would do the last part of it. But I agree with Joideep that if you do supine and you treat the coronoid as a coronoid, then you fix the olecranon, it makes sense. And then you go to the other side for the, I mean, you can just fix the radial head to the void. I used to use a Cocker approach for the radial head and not the void approach, because the void needs to detach the ligament. But I'm changing now after I've learned from Lee that this is a good approach. So the only thing I would change probably is that I would just fix the coronoid through the fracture side on lateral decubitus instead of supine.
And I have a last question about the soft tissue. I've seen that all of you don't use metallic anchors. There is a reason you prefer soft anchors or transossives repair?
Yeah, I used to use metallic anchors. I got no problem with metallic anchors, but they tend to be a bit bigger than the tiny soft anchors. So I like those little soft anchors because they're smaller. So yeah.
No, I think metallic are just fine. Most of us don't use it because they don't provide us with them, because the companies are not selling those, basically. But if you just have metallic, that's fantastic, no problem.
Okay, great. Thank you.
Thank you, everyone. It was great cases and great discussion. Thank you, Professor Antuña. Thank you, Dr. Phadnis, for sharing the cases and sharing the expertise with us. I think we have learned a lot tonight. And thank you again to all participants. And before concluding the session, I would like to encourage you to join our OSES community. You can scan on the screen this QR code, free junior membership. If you are under 32-year-old, it's free, so no reason for not joining us. And also, we encourage you to participate in these online shoulder and elbow school sessions. Lastly, you cannot miss the SESEC Congress that is taking place in September in Rotterdam. So thank you again, everyone, and good night.